So this is left revision Tympanoplasty. I already took a perichondrium graft from the tragus, the medial side of the tragus, because we have a really atrophic tympanic membrane. So this patient has been operated several years ago elsewhere, and what you can see, this is 12 o'clock, 3 o'clock, 6 o'clock. I've already elevated the the tympanomeatal flap, and what we can see here is the, of course we can see the, no, pardon, le cannelé mangeomarteau. You can see the round window and the round window niche here, and the promontory, the part of the fallopian canal, and of course the stapes, and you can see that we have a previous Incus autograft, which is completely dislocated and I think probably too short, which is of course the cause of failure, and so we need to change that. So first I will do the bony mirror resection a little bit larger. We do not have a clear curette, s'il vous plaît. We do not have a clear exposure of the fallopian canal, so I like to increase that to improve the exposure. So I'm doing the bony mirror resection with the curette. As you know, what I like to have as a landmark is of course the fascia nerve, but also the pyramidal process of the stapes tendon, and this is not the case here, because of course I will very probably use a TORP in this case. So I need to expose clearly the posterior half of the footplate, curette encore. Pretty strong hard bone. Okay, I think this will be much better now. You can see a little bit more the fallopian canal on the right. And now it should be okay. So of course this is again a transcanal approach. Aspiration, s'il vous plaît. And now we need to dissect this Incus Transposition, which means that we will probably create a perforation of the tympanic membrane, because the membrane is really atrophic. But that's not a problem for me, crochet house, because I already took the perichondrium from the tragus. C'est bouché. All right, so we're going to dissect now the Incus Transposition, cannelé normal. I need to check the stapes, but I don't have any doubt about that. It should be mobile, as you can see. It is mobile. You can clearly see the mobility of the footplate and the round window side, so it's fine. All right, donnez-moi les ciseaux, s'il vous plaît. I will first separate the residual, Incus Transposition by cutting the residual fibrous adherence to the stapes head, and I will try to remove this Incus Transposition. Cannelé mangeomarteau. Which is not going to be very easy, because you can see it's really moved anteriorly, and it's hypermobile now. Table en avant, s'il vous plaît. I will move the table a little bit more anteriorly to check the anterior part of the Incus Transposition. Stop. Which probably goes underneath the Malleus handle. Which is there. As you can see, the Malleus is there. Really anterior Malleus. Now this is the anterior part of the Incus Transposition. This is the left part of the autograft. I think it's gonna be fine, and I should be able to do it, to remove it soon. Ciseaux. Canne mange le marteau. You can see it's a really loose autograft. I will try to grab this entire part, and that's it. Alright, now we can remove it. La pince, s'il vous plaît. Pince. Okay, good. Alright, I'm going to check the tympanic membrane, but definitely there will be probably a tear and perforation. Vous pouvez appuyer devant, s'il vous plaît. Là. Ici. Au milieu. Au milieu, là. Voilà. Cannelé. You can see this atrophic tympanic membrane. There's no perforation, but I need to reinforce all these parts. So next step now will be to dissect the malleus handle in order to use it and to relocate the malleus handle. Alors, canne mange du marteau, s'il vous plaît. Alright, so we're going to dissect now the malleus handle. I want to relocate it. And this is not going to be easy. You know that when I talk about malleus relocation, I always insist to the fact that it's always better to not to remove the incus first prior dissecting the malleus handle, but in this case, of course, there's no choice. So you can see that it's much more tricky to dissect the malleus handle because it's pretty loose. I would love to use it, so I try to dissect it. If not, if I cannot use it, if I cannot dissect it, then of course I will use a TORP directly underneath the tympanic membrane. But I think that by using the malleus handle, this will increase the chance of long-term stability of the prosthesis, so I always try to use it when the malleus is there. Of course, we have the stapes, so I'm going to use the Silastic bending technique, which also helps a lot to have a great stability. But if I can also create a second point of stability from the malleus handle, I think it is better. You see, this loose malleus is really hypermobile, really loose. I think it's nearly done, and you see a big gap between a really anterior malleus and the stapes head. I'm going to try to stabilize the malleus with the suction tube, which is placed anterior to the malleus. Okay, now I'm going to use the micro ciseaux. Les micro ciseaux, s'il vous plaît. And I think it should be okay. Okay, calmez. Alright, I think it's fine. So again, I'm going to check the tympanic membrane. Very atrophic, but intact. So that would be a reinforcement of the tympanic membrane. Okay, so now I will relocate the malleus, so I need to cut the tympanoid tendon. Lancez-vous les directs, s'il vous plaît. Definitely, I will have a loose malleus for sure, because it was already loose before, but it will help anyway, I think, because I use this crochets. I use this prosthesis, as you know, with the groove at the center of the malleus head. So now I'm overstretching the anterior ligaments. I'm going to place the suction tube on the other side. And that's it. Okay, now it's fine, and we have a much better position of the malleus. Table vers moi, s'il vous plaît. So now what we need to do is to determine the length of the prosthesis. Stop. So I need to measure ciseaux. I need to measure the distance. Ciseaux. First, I will cut the tendon, because as you know, I'm going to use the band. Inspiration, s'il vous plaît. So first, I need to be sure that the malleus is on the good position. So I will reposition the flap, cannelé s'il vous plaît, in order to stick the malleus back to the tympanic membrane. Now, this is where I have a perforation here anyway, so that's fine, but this is at the level of the malleus handle, so it's fine. So there we go, and now I'm going to re-elevate the flap. The malleus is connected, so I'm sure that I will measure from the right position of the malleus handle. Mesureur. So I'm using this elongated Stapes measuring rod, which runs from 5 to 8 with 4 notches, 5, 6, 7, and 8 millimeter distance. I'm trying to determine which one is in front of the malleus handle. This is the second one, which means 6. So I will cut the prosthesis at 6.5. Allez, prothèse totale à 6,50. Mais d'abord, I will now reinforce the tympanic membrane. Cannelé mange le marteau before placing the prosthesis. There's a long history, as you can imagine, of repeated otitis since childhood. Right. I need to reinforce the posterior half of the tympanic membrane. This is because, of course, this is the place where the prosthesis head will be in contact with the tympanic membrane. Although I'm using hydroxylapatite prosthesis head, which is very biocompatible and very well tolerated by the tympanic membrane, I prefer to help the biocompatibility, reducing the risk of prosthesis extrusion by reinforcing the tympanic membrane like this. So I think this is not bad. Let's see, but I think it's going to be okay. If I stick it back to the tympanic membrane, it's going to be fine. Yeah, that's fine. Let me see, but I think it should be okay. Yeah, there we go. You see, it's all completely reinforced with the graft here, covering the bone of the ear canal also. Alright, so I'm relevating the whole flap now, including the graft. And now I'm going to place the TORP, of course. Crochet, s'il vous plaît. We've got a loose malleus for sure, but this is going to help. This is what I believe. Okay. So this is the prosthesis I designed with Grace Medical, a really good one with the band. So I'm going to cut it at 6.5, so I put it first at 5.5 and we'll pull it back at 6.5. So I'm going to cut now the proximal part of the shaft and then put it back at 6.5. Okay, there we go. Okay, good. And you see the band in the middle of the shaft. It's necessary to push the band a little bit lower. Alors la pince, s'il vous plaît, droite. should be fine here. So this will go like this, and the band on the other side will be this and this. Okay, first step here is to place the distal tip of the shaft of the prosthesis to the stapes footplate, and then introducing the malleus within the groove, and finally attaching the prosthesis to the stapes with the band. Alright, so first the shaft, so I don't care about the malleus first, I care about the prosthesis first, trying to place it at the right position related to the footplate. I'm going to place it like this, rotating the prosthesis a little bit in order to place the groove parallel to the malleus handle. I need to rotate it a little bit more, that's it. And now I will introduce the malleus. Causse Ear. So we need to grab, I'm going to hold the prosthesis with the sucker and just pull the malleus handle like this. It needs to go like this, and now I need to attach the prosthesis with the band. Cannelez s'il vous plaît encore, et ensuite le 3 de chouk. I prefer to have it in the middle of the stapes footplate if possible, like this. That's going to be really good. Okay, I will check it again, but first I need now to attach the prosthesis with the band to the stapes, and the band should go underneath the stapes standard like this. Cannelez. So of course you dislocate a little bit temporarily the prosthesis, but then we can reposition the prosthesis on the right way, and you see the malleus fitting very nicely within the groove, and they are moving together just like a single unit. Okay, looks good with a nice round window sign. So now we need to reposition the flap and see how it goes. I think it's fine, it's bulging a little bit, but it's okay. And I need to check if the prosthesis stays in the good position, which is the case here. I would love to have it a little bit more. I want to have a vertical position, so that's it. I think this is good now. Yeah, that is nice. Okay, finished. I just repositioned the whole flap now, and that's fine. Now putting the male cell, and that's the end. Alright, that was a kind of a basic surgery technique with TORP. Of course, many other surgeons would use a TORP in this case, but as you know, I prefer TORPs, but that's again a personal view, personal feeling, but so far, of course, absolutely fine. So thanks for watching, hope you enjoyed it, and see you again soon. Bye bye.